Okay. So, with everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Learn It, serving as an allocated session assistant to ensure a seamless experience. Learn It proudly stands as India's most relied upon digital platform, offering a multitude of enriching services accessibly for the doctors. It is with great pride that Clearnet serves as a digital partner for this event. And the focus of today's session is emerging trends in anesthesia. Now, I would like to invite Dr. Meenakshi Sundaram sir, our distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of Indian Society of Anesthesiologists and has held key positions including governing council member, president, and state secretary of the ISA Tamil Nadu state branch. Now, sir, we can proceed with the session. Over to you, sir.
Thank you very much. See, today we are happy that out of the 33 sessions we have conducted, very few sessions had complete lady strength, Nari Shakti. And today it is a complete lady strength, Nari Shakti. So we are not demanding 50% reservation for women. We are demanding now 50% reservation for men. I think 90% of the webinars conducted by Puthukkottai Bhudhan was participated by ladies only. So we are very happy because I used to say after obstetrics and gynecology, pediatrics was taken over by lady doctors. Now anesthesiology is completely eroded by the lady doctors and they have proven their strength. And today in this 33rd webinar, we are going to talk about modern trends in anesthesia. And at the outset, I have to inform the delegates also that I was mistaken by two doctors as a beautiful female by name Meenakshi, but it has not happened. So they have mentioned so many madams to me, but I am sorry that I happen to be Meenakshi Sundaresh. It is Meenakshi Sundaram means goddess Meenakshi is in Madurai. Everybody knows Meenakshi temple. So Meenakshi's husband is Meenakshi Sundareshwar, Lord Shiva. So this Madurai people, this Meenakshi Sundaram name is very common. So I am Ardhanarishwarar, even in the name, not in the namesake. In the name itself, I am having the Ardhanarishwarar, 50% male and 50% female. And with this, today we are very happy to have Dr.Rajni Khalia as the junior most faculty, that she is a SR in GMC Chandigarh. And she is a life member of ISA and RSCP Con. She is interested in obstetric and regional anesthesia, and she is interested in airway management also. So her hobbies are dancing and cooking. I think she will dance and her husband will dance to her tunes. I don't know, but she is a good dancer and she's a good cook. So I can believe that she's a good dancer because the DP says she's a good dancer. But cooking, I cannot guarantee. I have to ask her spouse only. So she's interested in cooking. And the advantage, the best part is she's not a simple dancer. In the Fanta Fiesta dancing competition in the school level, she has won so many prizes. So from the school days itself, she started dancing to the tunes of teachers, or I don't know, to the tunes of her parents. And even in college fest also, she has won the first place. So what I want to convey, people who are interested in any art from their childhood, since their childhood, they will succeed in that for years together. And another part, she's a born leader. She's a born leader because straight from the standard fifth up to MBBS, she was the class representative. Can you imagine? From the standard fifth to the MBBS level, she is the class representative. Usually, I have studied in government school in my school days, so I have not been exposed to convent. But I was informed that the class monitor will main the students. They will ask everybody to keep quiet, and they will inform if anybody talks to the teacher. That is the job. And Madam Rajini has done it very well from fifth standard to MBBS. That is, if anybody talks, she will talk, and if anybody talks, she will ask them to keep their mouth shut, and it will be informed to the class teachers. And see, she's a school captain in St. Joseph School, Chandigarh. So with all these extracurricular activities, she has sacrificed everything for the sake of medicine. She has sacrificed everything and she has entered into the anesthesia part. So we welcome you, and it will be followed by Dr. Ankita. Dr. Ankita is an assistant professor in GMC Chandigarh, and Madam has done 1.5 years senior residency in onco anesthesia in AIMS New Delhi, and in PGI Chandigarh she has done 1.5 years residency in general anesthesia. So she's graduated from Maulana Azad Medical College. And more than that, I used to say, because in Tamil, even 2000 years ago, it was said in ancient literature, if you are skillful, it will be respected throughout the world. So as Dr. Ankita is skillful, she was respected in the United Kingdom. She has clinical attachments in United Kingdom, and she is interested in pediatric anesthesia and obstetric anesthesia. She was a attending consultant in Max Super Specialty Hospital, and since March 2025, she is working as an assistant professor in Govt Medical College, Chandigarh. So we welcome Dr. Ankita. It will be followed by Dr. Deepika. Deepika is also a assistant professor in Govt Medical College, Chandigarh, and she got a fellowship of Academic College of Emergency Expert. The thing is, she's a ACLS instructor, ATLS provider. It is so nice to see a person who is good at cardiopulmonary resuscitation, is good at ATLS also. So she has acquired that FCCS in critical care, and Madam is a life member of ISA and RSCPCon, and she has published so many papers in national and international journals. She has been a part of authoring a textbook, and she is also interested in pediatric and obstetric anesthesia. And I was wondering, when she is learned ACLS and ATLS, she is interested in pediatric and obstetric anesthesia. That is surprising. But in addition, she is interested in airway. So at that particular point of time, we accept that she is a good resuscitator in ACLS and ATLS. She is interested in painting. I don't know, painting means it is wall painting or coloring the walls, or it is wall painting. I don't know, but she is good at painting. And when these three stalwarts are there, they need a good moderator. So that good moderator is nothing but other than Dr. Aditi. Aditi is AP in PGI Chandigarh, and she was informed, she was recommended to me by Dr. Suganya Mitra, and she's an associate fellow in NAMS, and she has done her DM pediatric anesthesia in PGI Chandigarh, and because of that only, even now she is looking like a child. So she is good at DM pediatric anesthesia, and she is a American Heart Association certified instructor, BCLS and ACLS. So BLS and ACLS, she is certified by American body. So naturally by Indian body also. She has acquired the best paper award from so many associations. So that best paper award, people got fed up by presenting the best paper award to Dr. Aditi, because all the associations, they cannot name so many associations. He got the thing. And in addition to that, in so many multiple indexed journals, she has published. Usually, the local people will publish their achievements only in newspaper, but she has published scientific papers in national and internationally indexed journals, and she is interested in pediatric anesthesia. No surprise about it, because she has done DM pediatric anesthesia, but she is interested in quality improvement. So for any BH accredited hospital, I think we can recruit to the services of Dr. Aditi, who can improve the quality, and I request her suggestions to improve our quality in the webinar presentation, so that we will oblige. And she is interested in reading and art. Reading means not anesthesia textbooks, reading novels. Art means I don't know what art. Art means she's the painter or chitrakar or bade kalakar. मुझे नहीं मालूम. लेकिन she is interested in reading and art. And with this introduction, I hand over the session to Dr. Aditi. Please go ahead.
Thank you, sir, for your very kind introduction. Without wasting much time, I think we will dive right into the theme for today, which is emerging trends in anesthesia. Our first talk will be delivered by Dr. Rajni, who is a senior resident at GMCH Chandigarh. She will be talking about green anesthesia. Over to you, Rajni.
Good evening, everyone. Today, I'm Dr. Rajni Khalia, Senior Resident in GMC at Chandigarh, presenting here practicing green anesthesia. Being in anesthetist, it is very important for us to be involved in green anesthesia for a safer environment and of decreasing the CO2 emissions from our side. Green anesthesia refers to the practice of delivering anesthesia in a manner that minimizes environment harm, which involves selecting techniques or equipments or by decreasing the energy use or decreasing the medical waste, and definitely without compromising patient safety or outcomes. Why is healthcare sector important, and what is the percentage of the environmental harm we do? It is estimated that an environment healthcare system provides 4.4 to 5% of total global CO2 emission, out of which an anesthetist or an OT product OT area produces around 1%, 1.1 to 1% of the total global carbon dioxide emission. And to this is the result of the disproportionate contribution of the uh, inhalational agents which have the high global warming potentials. Let's see what are the contributors. First of all, the most important contributors are the volatile agents like desflurane and nitrous oxide, and the other are the nitrous oxide, which is basically more important and more effective than the inhalational agents because they have a lifespan of approximately 114 years. And definitely with along with it, the high gas flows are also important. Since being using the older anesthesia machine, the high gas flows will lead to more consumption of both the agent and the energy. The last but not most important are the disposable equipments, which have been our lovables with sense of the readily availability and the ready single time use, and leading to increase in plastic and biomedical waste. Let's just have a look at what are the waste anesthetic gases and vapors contributing. So, if we compare the sevoflurane, isoflurane, nitrous oxide, and desflurane in the global warming potential years, comparing like taking carbon dioxide to be one as one, if we compare the sevoflurane contributes to 130 years, whereas desflurane to 2540 years. So if we compare the isoflurane and nitrous, it has 510 for isoflurane and nitrous oxide leading to 298 years. But still we consider nitrous oxide as bad because nitrous oxide is not only just contributing to the global warming potential years, it also has an atmospheric lifetime of 114 years, which cumulatively sums up to a more dangerous and a more hazardous global warming potential, and plus depleting the ozone layer. Let's consider this into a perspective of a flow of anesthesia or the flow rate of the anesthetic gases that we are being used. So, considering a patient going under anesthesia for 6 hours of a surgery in general anesthesia, if we consider a flow rate of zero point 0.5 liter per minute compared to a flow rate of 5 liter per minute in any of the agents, if we consider it for sevoflurane, it is 19 kilometers of a car driven at zero point 0.5 liters per minute, whereas for that same hours of surgery, if we are using 5 liters per minute of a flow, it will be equivalent to 184 kilometers of car driven. Similarly, For desflurane, if it is zero point 0.5 liters of per minute of flow used, it will be 898 kilometers of car driven compared to 9067 kilometers of car driven at 5 liters per minute, equivalent to a car being driven from LA to New York and back again. So, a crux of this, or a conclusion of this, I would suggest it is that not only the choice of agent matters, but hand in hand, the flow rates at which it is used is equally important. Let's see what are the strategies or what the new initiatives we can change for the greener practices. Most important or the important things are low fresh gas flows, which can be used. The second is to avoid high impact inhaled anesthetics like desflurane and nitrous oxide, preferring total intravenous anesthesia or regional techniques wherever possible, decommissioning or avoiding installing nitrous oxide pipelines as a new initiative that has been introduced, instead using the cylinders with the machines, and so that they stay closed when not in use, and decreasing the emission, and considering investing in waste anesthetic gas trapping. The minimal flow or the low flow anesthesia helps in three ways. One, it will be lung protective. Second, it will reduce the emissions. And definitely the most favorite thing of the corporate world, it will be cost saving. Let's revise the practices for greener anesthesia, sustainable agent choices, and the role of equipment and technology. Total intravenous anesthesia will definitely have a low atmospheric impact. Modern machines with accurate low flow delivery, charcoal filters, sevoflurane or TIVA, and to avoid desflurane and nitrous oxide, and closed breathing circuits to reduce the gas loss. What are the 5R? Not only the use of inhalational agent, but waste reduction is equally important for our OTs. The 5 R's of zero waste: reduce, reuse, recycle, refuse, and repurpose are important. There has to be segregation of waste at the OT level into infectious, recyclable, or the general waste, and avoiding unnecessary disposables and use of reusable things wherever possible, and in hand reducing the use of paper by using the digital record keeping to reduce the paper waste. Scavenging system is a very important part of eh, the green anesthesia, as it makes the waste anesthesia gases to be disposed of properly. Its main purpose is to prevent escape of waste anesthetic gases and to protect the staff. Secondly, it also helps to protect staff health by decreasing the chronic exposure risk leading to reproductive issues, headaches, and cognitive effects, and definitely reducing the greenhouse gas emission. The components of the system will include the gas collecting assembly, including the transfer system, the scavenging interface, open interface, closed interface, disposal system, which can be active or passive. The gas collecting assembly will include mask, breathing circuit, or ventilator connection, and transfer system, including the breathing system to the scavenging interface. The scavenging interface can be open or closed, and it protects the patient from barotrauma or suction related issues. The open interface basically releases the gases to the atmosphere directly, and the closed one uses the positive or negative pressure relief valves. Disposal systems can be active or passive. Active is preferred as it will be vacuum or section actively removes gases, whereas passive relies on positive insulation for releasing the gases. The green anesthesia consideration will be for these. Not only the active anesthesia gas scavenging system is important, definitely more important is the maintenance, so that we have to do the daily checkups, regular servicing of the AGSS walls, and the wallet to use the activated charcoal filters, and the adequate air exchanges that have to be 15 to 20 per hour. More not on it is always rightly said that not only one person can bring the change, it has to be a combined effort, which will be a more which will become make a improvement and a more significant change. So institutional initiatives are always needed and always welcome, including the greening the OR programs, making local audits or of how much carbon footprint has been generated by anesthesia, the green team formation, the education and awareness among theatre staff, which is the most important thing. Amongst the challenges, the first and the foremost is the cost concern, since the initiation or the initial investment in the green anesthesia is too high, whereas the eventually the cost will recover eventually, but in the first stage this cost will be too high. The second would be the resistance to change by the people and lack of awareness and training, and readily available reusable which are available in market, so people prefer using reusables. The Green Theatre project that was being initiated by NHS had 11 points. It was being initiated in 2020 to bring back the change and decreasing the carbon footprint by anesthesia or the OT in the hospital till 2040 and make a significant change. The first or the foremost change they made was to introduce low flow anesthesia and make the desflurane off the stock. So it decreased their consumption, CO2 consumption from emission from 45% to 50%. And also they introduced that the nitrous oxide was abandoned or only cylinders were used. The second change they did was their earlier surgical fluid suction was being packed in the plastic bags and went to the incinerator. Now they made a closed system. The suction jars were emptied in the drainage and washed there itself. The waste segregation was done at the source itself so that the reusable things and the disposed of things can be reused or managed accordingly. The conductive versus convective patient forming, comparing the fluid warm, under blanket of the patient and the bear huggers, comparing to the decreased around 10 times energy differences in the under blanket as compared to the disposables that were used in the bear forced air warmers. The other things that were being initiated was the efficient fluid warming, which was in which the fluid warmers was not used, so it decreased the plastic use and the cost, and definitely the electricity from 900 watts per unit that was being used with the fluid warmer to the 100 watt which was used with this efficient fluid warming. The anesthetic gas scavenging system switch was being turned off at some hours of the day so that it saves the energy being used. The theater ventilation was also set back for some hours of the day so that it saved 4000 watt per theater energy. The metal recycling reusable shower box was different and were reused again. Quality plastic recycling, if plastic can be reused, ban of the disposable cups and plastic, and the limiting the use of non-sterile gloves so that it can reduce the plastic generation. Last but not the least, as anesthesiologists, we can definitely make a change to the environment, and if we can, we should. As it is rightly said by Robert Swan, that the greatest threat to our planet is the belief that someone else will save it. Thank you.
Thank you, Dr. Rajni. You have very beautifully covered a very important topic, and I'm sure all our listeners will now be a lot more environmentally conscious. And as Sir has pointed out, in today's Nari Shakti, the most important Nari being Mother Earth, we'll all play a role in trying to protect her. So now we'll take the questions at the end of the three lectures. So we'll move on to the next lecture by Dr. Ankita Bhasin. She'll be talking on a very important topic, which is the role of point of care ultrasound for the today's anesthesiologist.
A very good evening, everyone. Thank you, Dr. Aditi, and thank you, sir, for the opportunity and for the introduction. So I'll be starting with the talk of point of care ultrasound for anesthetists. I'm Dr. Ankita Bhasin, Assistant Professor in Department of Anesthesia and Intensive Care. So the objectives of this session would be to tell you why you need to learn POCUS, how you can learn POCUS, and applications of POCUS in perioperative and critical care settings. I cannot teach you complete point of care ultrasound in 30 seconds, but I can tell you why and how you should make it a part of your practice. So let's start with the session. So point of care ultrasound. Let's first understand what is point of care. Point of care means provision of care and diagnostic testing at the time and location of care. So these days, like point of care coagulation testing, point of care testing they are trending because it actually saves time, and actually it's less cumbersome for the patients because the decisions can be made bedside. So like that, we have point of care ultrasound. So point of care ultrasound is focused goal-directed bedside sonographic examination. The most important point is it is performed and interpreted by the attending physician bedside and not by a trained radiologist or a cardiologist. And it complements the history, physical examination, other clinical tests to make a rapid diagnosis. Also, it also helps to perform procedures, a lot of procedures safely. Now we can see and do the procedures. The most important question that comes here is, can ultrasound replace stethoscope? The answer is no. As I have said, it complements history, physical examination, and other modes of examination, but it cannot replace it. Stethoscope helps you to listen, while ultrasound helps you to hear. So it can never replace, but yes, it can definitely be an essential part as we have stethoscope today. So let's understand how ultrasound works. So ultrasound waves are mechanical or longitudinal sound waves with frequency above the human hearing, very high frequency. It needs something to travel, it needs tissue or fluid to travel, and it cannot pass through air or bone easily. So the clinical implication of this is whenever you're doing an ultrasound, you need a jelly so that the air interface is removed between the patient and the probe. So it works on the piezoelectric effect or pulse echo principle. So whenever the ultrasound probe, which has piezoelectric crystals, electricity is passed through it, it emits ultrasound waves. The ultrasound waves goes to the organs, return from the organs, and these waves are collected by the transducer itself and an image is created. So based on attenuation and reflection, you get an image which is either white or some parts are black, anechoic or hyperechoic. So like that, you're able to differentiate what the structure is. So let's first understand what are the advantages of point of care ultrasound. Most important, the ultrasound gives you real-time high quality image. So the image that you get, it's then and there, whatever is happening at that moment. The next important point is serial examination. If you want to see, for example, if you want to see IVC every hourly, you will be able to do ultrasound very easily bedside. But if you want to do any imaging or radiology hourly, that will be really difficult because you need to take the patient to the radiology suite and a lot of radiation exposure is also there. So serial examination can be done with ultrasound. There are no radiation or risks with ultrasound, so hence it's safe even for pregnant females, pediatric patients, and it can be done as many number of times as much as required. It can be done bedside instantly. And nowadays, apart from portable, we also have handheld ultrasound probes also. You can just keep it in the pocket. Also, there are a few restrictions on these probes in usage in India, but if you go to other countries in the world, people actually buy them and keep them in the pockets, and whenever they want to do the ultrasound, it just gets connected to your phone and you can acquire an image and interpret it. It also reduces the need to involve a second clinician. It saves time. You don't need to, always call the cardiologist or the radiologist are not always available, especially out of hours. So if you know how to use point of care ultrasound, it's actually very advantageous. It makes you independent. And it's very precise. For these days, procedures are very safe due to ultrasound. As we have already discussed, you can see and do the procedures, less complications, and first attempt rates are very high with ultrasound. So now what are the challenges associated with point of care ultrasound? So in India, there are some legal restrictions. So the PC-PNDT Act was enacted to prevent misuse of ultrasound for sex determination and female feticide. So it is specific to India. So because of this act, we have a few restrictions which are not there in other countries. So there are challenges because of this for its widespread use and easy availability. So the restrictions, you should know about it because these are the rules and you can actually, if you do not follow them, you can actually be in trouble. So first is the records need to be kept and they have to be maintained where you're using the ultrasound. And if the ultrasound machine is purchased for a particular area, it cannot be shifted to a new location without a prior approval. That gets a bit cumbersome and it's a bit costly in that sense because we need to buy separate ultrasound machines for ICU, separate for operation theaters, another one for emergency. So you cannot actually, move the machine from one place to the other. The other is an individual cannot buy a handheld ultrasound in India, unlike in other countries. Handheld ultrasound has same rules as portable ultrasound and it needs to be bought by an institute or a hospital. So as of now, we cannot own an ultrasound machine at an individual level. The next is if you have any non-compliance with these rules, the problem can even go up to imprisonment. So other challenges is that focus is not yet even in our academic curriculum or core competencies. So the NMC guidelines for postgraduate training for MD in anesthesia states that the student should be able to give block, peripheral nerve blocks, and use ultrasound machine for blocks and venous cannulation. However, we are still not clear how what are the core competencies of usage of ultrasound in terms of medical diagnosis or in critical care, and how do we document it. So the curriculum need to be more elaborate on this on point of care ultrasound in India. The next challenge is the learning curve is steep. You need to learn how to acquire the image and interpret it, and then how to make decisions according to that. And interpretation is very subjective, depends upon the expertise of the user. And also documentation in medical legal issues related to the unavailability of the core competencies, as well as we do not know how we can use the ultrasound images and who can use it, and when can we get a medical legal problem if we do not use it. And also, it's not always easy to acquire the images. For example, if intraoperatively a major abdominal procedure is going on, you cannot actually, it's not easy to acquire subcostal views. And in critical care patients also, supine patients on positive pressure ventilation, difficult to acquire cardiac views in these patients. So another important point to understand is that if you're not able to interpret the image, that doesn't mean that you say that the image is normal. You can say that the image, we cannot interpret the scan, we were not able to do the scan. Do not say that the scan was normal. So now let's understand how we can acquire the skill of point of care ultrasound. So if you need to acquire the skill of point of care ultrasound, you have to be a little bit systematic. So the very important framework you can use to learn about ultrasound is I-AIM framework. I for indication, A for acquisition of image, I for interpretation, M for medical decision making, and we have added another P to it, which is psychomotor skills for performing procedural guidance procedures with ultrasound. So let's go deeply into each and every point of this framework. So indication. So before you do ultrasound, you need to know why do you need it. For example, if you want to learn gastric ultrasound, the most important thing that you need to know is where do you use it? Where do you need it? You need it in, for example, in preoperative period to find out whether the patient has empty stomach or full stomach. Next is acquisition of image. To acquire the image, you should have knowledge about ultrasound physics, its anatomy, as well as sonoanatomy. You should know how the stomach, what is the anatomy of the stomach, and as well as when you make the image, how does it look on the ultrasound, as well as the basic ultrasound equipment physics. The next thing is interpretation. You need to understand what a normal stomach looks like, for example, and what abnormal or full stomach looks like, what a empty antrum looks like. And last is medical decision making. After you have acquired the image, now you need to make a decision based on the image. For example, if the stomach is full, what you're going to do next? Are you going to cancel the case, or are you going to induce the case based on rapid sequence induction? So this is the framework in which you can learn the ultrasound in each and every organ related to point of care. The other last part is psychomotor skills. If you need to perform any procedure with ultrasound, the most important thing that you need is hand-eye coordination. You need to practice needling on a phantom. And the most difficult or challenging step is to visualize needle at all the time. And that is what you need to practice on the phantom before actually doing it on the patient. So it needs some time, but it's doable. So let's just touch upon physics and technical facts of ultrasound. I cannot touch it. I cannot talk about this in detail, but I can definitely tell you that what all things that you need to know. It's a separate lecture in itself. So you should know about the modes of ultrasound: the B mode, the M mode, and the Doppler mode. So these are there in all portable ultrasound machines. The B mode is the basic brightness mode in which you see a structure. The first image that you acquire is the image in the B mode. Basically, you differentiate between different types of structures. The fluid looks anechoic, the lung or the bone looks hyperechoic, and some structures look hypoechoic. And the another one is the motion mode. So motion mode is important for us. For the most commonly, it's used to diagnose a pneumothorax. So basically, to know the movement of the structures in that line, in that particular line is the motion mode. So it's whenever you do a motion mode on the lung, if you get a sand on the beach appearance, that's no pneumothorax. And if it's a barcode appearance, that means there is pneumothorax. The color flow mode is basically just to see whether the vessels are present or not present. If you are performing a block and if you put the color mode, and if there are any vessels, the vessels will look either blue or red. The most important for us for performing central venous access is pulse wave Doppler. Pulse wave Doppler actually tells you the kind of flow in that vessel. So if the flow is pulsatile and it's triangular, it's an arterial flow, and if it is band-like and continuous, it's a venous flow. So other things that you need to know about is about the probes, the linear, curvy linear, and the phased array probe. The linear probe is high frequency probe. You can see superficial structures very nicely, beautifully, but you cannot see the deep structures. The curvilinear probe actually shows you the deeper structures, but the resolution is not that good. While the phased array probe has a small footprint in the superficial part and a larger footprint at the deeper part, so it is actually made to see the heart. But it can also be used to see lungs or maybe IVC or some structures in the abdomen. The next thing that you need to understand the probe movement, like the movement currently which is happening is the sliding, and the next movement is tilting, and then the compression, rotation, and rocking. So it's very important to understand these motions because they can be used to actually acquire an image and or optimize the image. The other thing that you need to understand is the type of imaging planes or the orientation, the long axis plane or the short axis plane. The long axis plane means the plane is parallel to the length of the structure, while the short axis plane means the plane is perpendicular to the length of structure. So another most important aspect that you need to understand is about the image optimization. You get an image, but that image is not always great, and you should have the skill to optimize it so that you can perform or interpret the image in a better way. For example, if you want to do a central venous access in the IJV, and if you have acquired this image, you should know that what a good image looks like. So there are three things that you need to adjust, that is exam, gain, and depth. And exam actually it's something which is inbuilt in the ultrasound machine. You can choose the vascular mode or the nerve mode, and the gain actually adjusts the brightness of the structures, and the depth. The depth should be adequate enough, for example, to see the artery and the vein. The depth should more than this depth is not required for this particular image. So the depth should be adequate so that you are able to interpret the images. And the other part is ergonomics. So whenever you are performing a procedure, the first question that comes to the mind or is asked to you is, where do you keep the ultrasound? Which side, this side or that side, right side or the left side, in front of you or at the back of you? So the ergonomics is very important. So the most important point is the operator, the needle, and the transducer and the ultrasound should all be in one line before you perform the procedure. So that is what the best ergonomics are for performing ultrasound-guided procedures. So next, let's talk about applications of point-of-care ultrasound. So I will tell them in form of a scenario based so that you're able to understand how you can use it on daily basis and in life-threatening situations. So challenging peripheral intravascular cannulation. So for example, you're posted in ICU or you get a call as an anesthetist from the ward that there is a cannulation. And obviously you do not have these kind of veins all the time. The actual kind of veins that you have is this. So you're not able to cannulate or put an intravenous cannula anywhere here in the forearm. So what do you do? So what do you do? What is your next step? So usually, if you do not use ultrasound, you'll say, I'll put a central line, or maybe we'll take a consent, but central line is a bit invasive. But ultrasound can actually come to your rescue. As you see, the veins here in the arm, they are deep veins and they are not touched. They are untouched because they are not visible, basilic, brachial, and cephalic. So you can actually use ultrasound to visualize these veins and put the cannula in here. So next, let's understand about the role of ultrasound in challenging neuraxial anesthesia and lumbar puncture. Your expectations while you do spinal epidural, almost, I think it's a very common practice. Everybody does it, maybe daily or every alternate day. You expect the spine to be, good spine, but usually the case is not it's not the case all the time. For example, you may have a case of ankylosing spondylitis, or you may have a case of scoliosis. You may have an obese patient in which you're not able to see the midline, or you may have a patient with a metal work. So what do you do in these challenging cases? You do not do spinal, or you do not do epidural? Well, you can actually do it. And you can actually do it in very less attempts if you use ultrasound. So ultrasound guided neuraxial anesthesia, you need to acquire just two images. The first is transverse midline view, to find the midline. In case in an obese patient, you're not able to find the midline, then you can use the transverse midline view to actually find the midline, the spinous process. And it will just give you an idea. You know where to start. Then you will get an idea that where do I need to start? Where do I need to put the needle? And the second view that you need to acquire is paramedian sagittal oblique view. So this view actually tells you about whether the space that you want to put epidural or spinal is that space wide enough through which you can go. If a patient has the spaces are very closed or not very open, so this view can actually help you get that. If you're able to see the anterior complex, so that means that space is fine, and you can actually put an epidural needle or a spinal needle to do the puncture. So next, confirming position of Foley's catheter or malfunctioning catheter. You have a patient in a post-operative period, post-spinal anesthesia, and the sister is saying that the patient doesn't have urine output, and we are not sure whether the Foley's is not working, or is it not in place, or whether the patient has not produced any urine output. So what do? Just put an ultrasound probe on the lower abdomen in a transverse section, and you will be able to see a distended abdomen, distended bladder with a Foley's catheter in situ. So this shows that definitely the bladder is distended, so the Foley's is not able to drain the urine. So that means the Foley's is probably malfunctioned, but it is definitely in place. It's in the bladder. If you want to diagnose urinary retention, you can easily do that again by seeing a distended bladder in the postoperative period. So next, you get a patient post TKR, day 6 or day 7, comes with the swollen limb, redness, dyspnea, and now you think that the patient has lower limb DVT. So what do? So instead of just calling to the radiologist, you can do a simple compression scan, and you can check whether the veins are compressible. It's just a 2-point or a 3-point scan in the lower limb, and you can easily make the diagnosis. And if the veins are not compressible, then you'll be able to start the treatment early on and not wait for the specialist consultative radiology, imaging, or ultrasound. So goal-directed fluid therapy in perioperative and critical care. So we know that hypovolemia causes hypoperfusion, AKI, hypotension, tachycardia. Fluid overload causes edema, surgical complications, pulmonary complications, and we need to find that sweet spot where the patient is euvolemic or very adequately resuscitated. Easier said than done. It is very difficult to find that sweet spot. So there comes the role of goal-directed fluid therapy. You have a goal to which you target. So the very commonly used goal is either IVC diameter. It's used in critical care as well as in perioperative period, IVC diameter or IVC collapsibility and distensibility index. So serial examination can also be done to assess for fluid responsiveness. Preoperative gastric ultrasound, a very big confusion for it. We all follow NPO guidelines, but what if in a semi-emergency case comes, for example, a patient with eye injury, and the surgeon says the patient just had bread 3 hours ago, and we are not sure whether we should take, the decision is yours. So do you want to take it now, or do you want to wait for the NPO period to be over? So what do? You want to see the antrum. You put the patient in left lateral decubitus position, make this image, and you want to see the antrum. If this antrum is empty, so that means the patient can be easily induced with normal general anesthesia induction. What if the appearance is like this? This is starry night appearance. It happens when the patient had a lot of fluids. And what if the appearance is like this? So this is a frosted glass appearance. This happens when the patient has taken a lot of solids. So after this qualitative assessment, you can actually calculate the gastric volume from the cross-sectional area of the antrum. And then you can actually decide whether you want to induce the patient with rapid sequence induction, or you want to wait, or you can induce it with normal induction. So now ultrasound-guided regional nerve blocks. So regional nerve blocks have actually evolved a lot. And now I'll tell you how it has evolved and how the safety has increased from the previous blocks, how we used to perform it till now. So the aim is to deposit local anesthesia close to the nerve and avoid any intraneural injection. So how do you do that? So earlier we used to do a landmark guided technique. Just put the needle, elicit paresthesias and give the drug. But there is a very high risk of nerve injury here. So the peripheral nerve stimulator came. So you need to adjust your milliamperes of current, and you need to see at what current does there are paresthesias or there is a motor movement. But this was also not safe enough because we were not able to see where a needle is going. So hence the ultrasound came. Now we can actually visualize where the needle is going and whether it is near the nerve or whether it is away from the nerve. But what if the anatomy is not that good? So now they say that you can use ultrasound guidance with peripheral nerve stimulator guidance, or you can use ultrasound guidance with peripheral nerve stimulator guidance or plus injection pressure guidance. If the pressure is really high while you are injecting, then it's probably very near the nerve or intraneural. So that's how ultrasound has actually evolved our regional anesthesia techniques. So these are the photographs of image of the Plan A blocks. Plan A blocks are the blocks that should be known by all anesthetists. And the other blocks can be known by the regional anesthesia experts. So all these blocks, axillary, interscalene, rectus sheath, femoral, adductor canal, or popliteal nerve blocks, these all should be known by every anesthetist, and these should be performed by you only under ultrasound guidance. There are some blocks which cannot be performed blind, for example, rectus spinae, or probably or adductor canal block. So diagnosing raised intracranial pressure, you get a patient who has severe headache and you want to see whether the patient has raised ICP or no. You put a probe just on the eyes. After putting a tegarum, just make sure the eyes are safe. And then you want to see the optic nerve sheath diameter. The optic nerve sheath diameter is, if it is more than 5 mm, if it is more, then that means that the patient might have raised ICP. So how do you interpret it? So if it is more than 5 to 6 mm, more than 6 mm, definitely the ICP is raised. If it is less than 5 mm, normal ICP. If it's somewhere between 5 to 6 mm, you go and see papilledema. If there is no papilledema, ICP is normal. If there is papilledema, ICP is probably elevated. So you can make decisions to, give treatment to reduce ICP, and then you can again check the ONST, because ONST responds to treatment, the diameter. So next, procedural guidance. So ultrasound for central venous access. The first question, should it be standard of care? Well, it is a standard of care. Well, blind versus ultrasound. The debate is already over, but the reason is, I'll just share that. So the target is that you have to safely perform the procedure with no complications, especially no immediate complications. So the immediate complications are pneumothorax, bleeding complications like hematoma, arterial puncture, or catheter malposition. Well, use of ultrasound has definitely reduced these immediate complications. And apart from that, it has also improved the overall success, first-time success. Be it any kind of IJB, be it collapsed or a hypovolemic patient, well, with an ultrasound, if you are effectively trained, you can actually insert the central line in one go. So there are a few clinical scenarios where ultrasound-guided central venous access is very useful. For example, if there is aberrant anatomy or aberrant vascular variation, thrombocytopenia, coagulopathy, you cannot afford an arterial puncture. Ultrasound is just very important. Hypotension or shock on peri-arrest states when the patient is hypovolemic and the veins are all collapsed. History of multiple prior cannulations. Again, you want to rule out any thrombus in that, then ultrasound is useful. And challenging patient anatomy, obese patient, burns patient, or edema where you do not know how the anatomy looks like. Be it any kind of cannulation on any site, high IJB, low IJB, supraclavicular, subclavian, intraclavicular, subclavian, axillary, femoral. Ultrasound can be used anywhere, and it has actually improved the safety and efficacy. Now, if once you have put the catheter, now there are a few things, a few steps because of ultrasound which have actually improved the safety. For example, you can confirm the guide wire in the vein, and you can actually be sure that the guide wire is in the vein and not in the artery before dilatation. The other thing, you can actually confirm the catheter itself once you have inserted. Now, once you have put the central line, you want to make sure whether the central line is in SVC or whether it has gone in other IJV or the subclavian. So what you can do is you can do a echocardiographic bubble test or agitated saline. So just push 20 ml of saline, and if you see through the distal port of the central line, and if you see these starry bright appearances, that means the central line is in SVC. So that's echocardiographic bubble bedside bubble test. If you really want to confirm the central line position immediately, and you have to use the central line bedside. So the other ultrasound-guided procedures are thoracocentesis, pericardiocentesis, paracentesis, arterial line insertion, on-arrival ultrasound-guided blocks for pain relief in trauma, blunt trauma chest, for rib fractures or limb fractures. All these procedures can be done with ultrasound. Now let's discuss some life-threatening emergencies in which ultrasound can actually come to your rescue. Cannot ventilate, cannot intubate. For example, you have an anticipated difficult airway, a burns patient, and you think that you might land up into a CVCI situation and you might have to do a cricothyroidotomy. So what you do? You put the probe here longitudinally on the trachea. You can see the pearls, ring of pearls, which are the trachea, the tracheal rings. This is the air interface, and this is the cricoid, and this is the thyroid. So you can actually mark the cricothyroid membrane here before you attempt intubation, so that it's easier for you if you land up in a situation like this. You have a patient with dyspnea of unknown origin. So what are the differential diagnoses in your mind? It's either pulmonary edema, obstructed lung disease, pneumothorax, or pneumonia. Ultrasound can actually help you differentiate and find out the real cause. So how do you do it systematically? So if the patient has B lines and pleural effusion, and you see the IVC and the IVC is plethoric or the ejection fraction is low, then definitely the patient has signs of heart failure or hypervolemia. The patient has pulmonary edema. If the patient has normal lung, normal A lines, and then you suspect either the patient has pulmonary thromboembolism or the patient has obstructive lung disease. So how do you differentiate? Just see the RARV is dilated. And if the DVD scan is maybe positive, then query PTE, pulmonary thromboembolism. If the patient has pneumothorax, then you can actually see the absent lung sliding sign. But to differentiate between pneumothorax and atelectasis, what you need to do is you need to find a lung point. If the lung point is present, that is definitely a pneumothorax. If it is an ARDS, then there is focal patchy B lines. So that's how you can use ultrasound to actually in the emergency situation of undifferentiated dyspnea. Now, next, use of point-of-care ultrasound in undifferentiated shock. If the patient has come to you with unknown hypotension, what you need to do is you just need to see the thorax, the heart, and the abdomen with the ultrasound. And then you can actually interpret and maybe find out what is the type of shock. So to differentiate between the type of shock, you have to see the pump, that is the heart, and the tank, that is the IVC, and maybe lungs or other organs. So if the pump is dilated or not working, and if the IVC is full, and if there is diffuse B lines in the lung, that means it's probably cardiogenic reason. So if the ventricles or everything is normal and they are would you see a sign on the short axis that is kissing ventricles and is IVC is collapsed? And if there is any sign of any blood or free fluid in the abdomen or bleeding, then that means the patient has hypovolemic or hemorrhagic shock. If the RARV is dilated and IVC is full, then maybe the patient has pulmonary thromboembolism. And if you want to diagnose tamponade, then you can actually see a pericardial effusion in the lax view or subcostal view. So now, point of care ultrasound during cardiac arrest. We all know about ACLS algorithm. Start CPR, when to give shock, when to give CPR, you have to continue CPR, do not interrupt CPR. But the point here is this one. Find the reversible causes and treat. It's very easy to say, but it's very difficult to find out the reversible causes at that time and to treat it. So ultrasound again can come to the rescue in the same way you use it to differentiate. So ultrasound can actually help you diagnose hypovolemia, as we have already discussed, tension pneumothorax, tamponade, pulmonary thromboembolism, and coronary thrombus if there is regional wall motion abnormality. So actually, it can help you to find the cause of cardiac arrest and to treat it in time. Now, the most important step here is you do not have to interrupt the CPR due to point of care ultrasound. So when do you do the point of care ultrasound? They say that this is the compression zone, CPR is ongoing. So while the CPR is ongoing, maybe you just try and put the probe on chest. And once there is a 10-second pause for pulse check, during that time, you can record a clip. And while the CPR is ongoing, you can actually review the clip and make some diagnosis and go for treatment. But the most important point is here, use the POCUS, but it should not interfere with CPR. And there should be one person who just is there to do the POCUS, to record the clip and to interpret it. During cardiac arrest, you do not get ATCO2. You are not able to see the chest rise because the CPR is ongoing. So how do you confirm whether the endotracheal tube is inside or no? So if the endotracheal tube goes inside the trachea, the esophagus looks collapsed as there is no air here. But if the endotracheal tube goes into esophagus, there is air in the esophagus also. So it's a double tract sign. So that's how you can use it to confirm intubation. So just to summarize, there are the uses of perioperative POCUS in preoperative, intraoperative, and postoperative period, how you can use it. Preoperatively, you can use to do gastric ultrasound or predict difficult airway. We have not discussed it, but yes, definitely to predict difficult airway. Evaluation of cardiovascular pathology. Intraoperative, you can use to do procedures, neuraxial, nerve blocks, and you can also use it to find undifferentiated hypotension intraoperatively. Postoperatively, you can use to diagnose postoperative urinary retention or undifferentiated hypotension or DVT. So the list is endless. The only metaphor I can come up with is that the probe is just like a third eye at the bedside. You can see, put the probe anywhere and see. To summarize, POCUS is an integral part of anesthetist clinical practice, and it has numerous applications. Acquiring this skill requires systematic training. Thank you. So these are the suggested readings. Just wanted to say that this is the book that I recommend. It's from our beloved senior, Dr. Gaurav Mittal, who unfortunately is not here with us. May his soul rest in peace. Thank you so much.
Thank you, Dr. Ankita. You've covered the whole spectrum for POCUS very well.
Thank you, ma'am.
So I'm sure the ultrasound will now become everybody's best friend, and everybody will try and use it as much as they can in both the perioperative as well as the intensive care setting. But just a word to our listeners that it's all about practice, practice, and practice. You'll have to keep reviewing your skills to make yourself better and more proficient with this wonderful device that we now have with us. Okay, so our next talk will be taken by Dr. Deepika, and she'll be talking on the very interesting topic and a very emerging trend indeed, which is artificial intelligence in anesthesia.
Good evening to all. Thank you, sir, and Dr. Aditi. Myself, Dr. Deepika, will be discussing about artificial intelligence in anesthesia. So, first of all, I will be discussing about the contents. We'll be discussing about definition of artificial intelligence, uses of AI in healthcare, history of AI, what AI is actually, machine learning and its types, the techniques in AI, themes of applications of AI in anesthesia, future of AI, and the limitations of AI. So, starting first, science and engineering of making machines intelligence. That is called artificial intelligence. The term was first introduced by Dartmouth Workshop. The term coined by American scientist John McCarthy. Fathers of AI, John McCarthy, along with Marvin Minsky. In 1956, they defined it as a capability of computers to respond in a manner resembling human intelligence. So when the computers start responding like humans, it is called artificial intelligence. It is a broad concept of machines designed to understand and perform the task on their own in a smart manner. The study of algorithms that give the machines the ability to reason and perform functions such as problem solving, object and word recognition, and decision making. So, on the behalf of humans, the machines will start taking decisions, problem solving, and word recognition, etc. So, AI in everyday life. Where are we using AI in everyday life? It is for facial recognition in passport offices, voice recognition by virtual assistants like Alexa and Siri, scheduling airlines and hotel bookings, computer games, web search engines like Google, language translation, robots, etc. So, artificial intelligence in healthcare. It can be used in managing medical records and data, digital consultation, analyzing the healthcare plans and treatment design, drug discoveries and development, surgical treatment, personalized treatment, continuous remote monitoring and diagnostic, and clinical trial research as well. So, what is the history of artificial intelligence in anesthesia? Anesthesia was the first of all to introduce artificial intelligence. In the first instance, the anesthesiology first established the concept of the PK/PD model of clinical drugs, like called the pharmacological robots. Followed by it in 1950, the Brickford uses the EEG signals to monitor and maintain the depth of anesthesia. Followed by it in late 80s, the first CLAD system was created by Chevron and colleagues. They designed the CLAD system. Followed by that, the servo anesthesia theory system, embryonic form of automated anesthesia and robotic anesthesia was used. In 1990, the development of computer technology, TIVA TCI, was applied in the clinical practice. Max Sleepy came into vogue in 2008 on closed loop feedback system, and followed by that, Sedasi pharmacological robot was designed to control the hypnosis and analgesia. What are the new technologies in anesthesia in intensive care? New technologies in anesthesia in intensive care include the simulation. There can be simulators, will help in learning and cater more to the patients. Telemedicine can be come into vogue, and followed by artificial intelligence, which inculcates all the areas of anesthesia, perioperative medicine, intensive care, and emergency medical services as well. Why? Why are we requiring artificial intelligence? There are three factors that form the backbone of AI have contributed to rapid development and are as follows. Because of large data sets, rapid processing of improved hardware that perform large processing tasks, and the new wave of AI architecture and algorithm. So to handle the large database and to large hardware, so we can use AI. What are the benefits of artificial intelligence? There can be no human errors. Humans cannot be present 24/7. So artificial intelligence have taken over the place of humans. Unbiased decisions can be done with the help of artificial intelligence. Quicker decision making is there. There are no risks involved. Healthcare applications are being updated with the help of artificial intelligence, and managing the recurrent tasks can be there. So, what does artificial intelligence incorporate? It's a program that can sense, reason, and act and adapt. It incorporates machine learning. Machine learning, and it has algorithms whose performance improve as they're exposed to more data over time. And machine learning itself incorporates deep learning. It is a subset of machine learning in which multi-layered neural networks learn from vast amount of data. So we are training the machines with the help of data to learn, and then produce results. So what is machine learning? Machine learning is a subfield of AI defined as training a computer or system to automatically learn from its input, improve from the experience, and react to the data without explicit programming. Machine learning allows software applications to become more accurate. So, types of machine learning, it can be of 3 types: supervised learning, unsupervised learning, and reinforcement learning. Coming on to one by one, supervised learning. Supervised learning is a task-driven process in which the algorithm is trained to predict a specified output, such as recognizing a cat. It uses a labeled data. So, a training data set that allows the machine to analyze the input and learn association between the input and the desired output. The test data set allows for assessment of performance of algorithms on the new data. This learning model takes input and maps that to known output. So we are training a cat. So the supervised learning methods need external supervision and train machine learning models. We are training the model to recognize a cat. They need guidance and additional information to return to the desired result. Unsupervised learning, it identifies the pattern of data without predefined labels. Unsupervised learning refers to the algorithm identifying the patterns or structures within the dataset. This model does not have a fixed output variable like the supervised learning model. Unsupervised learning finds patterns and understands the trends in the data to discover the output. The model tries to label the data based on the feature of its input. The training process used in supervised learning does not need any supervision to build the models. They learn on their own and predict the output. So the model can be trained to recognize a bus, or it can be trained to recognize a truck. Reinforcement learning. Based on the reinforcement learning refers to the process by which an algorithm is asked to attempt or train a certain task and to learn from its subsequent mistakes. A biological analog to reinforcement learning is operant conditioning, where the classical example of a rat taught to push a lever through use of food-based rewards. This learning model trains the machine on trial and error basis to take best action by establishing a reward. It tells the machine when it made decisions correctly, which helps it to learn over time what action should be taken, like a feedback system. So after accomplishing the task, the agent receives a reward. If the task is not achieved correctly, there can be a penalty. An example could be to train a dog to catch the ball. If the dog learns to catch a ball, you give it a reward, such as a biscuit. Reinforcement learning methods do not need any external supervision to train the model. So, what can be the techniques in artificial intelligence? It can be 4 types: fuzzy logic, classical machine learning, neural networks and deep learning, and Bayesian methods. First, coming on to the fuzzy logic. The term fuzzy refers to things that are not clear or vague. Approach to computing based on the degrees of truth. A numerical value between 0 and 1, rather than the usual true or false, 1 or 0. The Boolean logic on which the modern computers are based. So, fuzzy logic, we can get any answer between 0 and 1. Whereas in Boolean logic, we can get an answer as yes or no. In place of true or false, fuzzy logic provides a very valuable flexibility for reasoning. Example is an anesthesia monitor using fuzzy logic to detect hypovolemia to approximate the presence of mild, moderate, or severe hypovolemia based on the normalized values of heart rate, blood pressure, and pulse volume that were categorized into mild, moderate, and severe. Using fuzzy logic, if heart rate is mild and blood pressure is mild, pulse volume is severe, then hypovolemia is moderate. The development of such rules require expert human input to determine appropriate rule set for the machine to follow. Classical machine learning. It uses feature or properties within the data to perform the task. The features are selected, handcrafted by experts to help guide the algorithm in the analysis of complex. For example, guide the algorithm in analyzing complex data, such as patient demographics, vital signs, and aspects of their medical history, and optimizing patient-controlled analgesia dosing regimes. So we can input and we can get a result. The decision tree contains a set of techniques which uses flowchart-like tree models with multiple branch points to determine the target value. Each node within a tree has assigned value and final node represents an endpoint. Third is the neural networks. Neural networks are the most popular methods. They can handle the complex data. Neural networks are inspired by biological nervous system and process signals in layers of computational units. Each network is made up of 3 layers: the input layer, the hidden layer, and the output layer. The input layer describes the data. The hidden layer conducts and different mathematical transformations can occur, and the output layer gives the desired result. Between each layer are multiple connections of the neurons that parameterize to different data. Thus, neural networks are framework within which different machine learning algorithms can work to achieve a particular task. Deep learning. Deep learning, it is an extension of neural networks that use many layers to learn more complex patterns, like convolution neural networks, recurrent neural networks. Unlike in classical machine learning, the features are handcrafted. Deep learning itself features based on the data itself. It analyzes all the available features within the training set. So deep learning is a potential powerful tool to analyze very massive data sets. So differentiate between deep learning and machine learning. In machine learning, there is a human who is collaborating the data and giving it to the computer. Whereas in deep learning, the data is extracted and corroborated itself. The fourth one is the Bayesian methods. Bayes' theorem are the distribution of the probability of an event based on the previous knowledge or data about the factors that may influence that event. It allows both for modeling of uncertainty and updating or learning repetitively. Bayesian techniques have been incorporated into common tasks like spam filtering, financial modeling, and evaluation of clinical tests. So, where can the artificial intelligence be applied? AI can be applied in all fields of anesthesia, like AI in pre-anesthetic evaluation, AI in intraoperative anesthesia, AI in the postoperative area. So, AI in the pre-anesthetic evaluation, it can evaluate the ASA physical status of the patient. Postoperative risk assessment can be done, as well as the airway assessment can be done. ASA-PS classification is subjective and requires manual clinical review at risk stratified patients. Zhang et al. Aim of developing the system that automatically generates AS-PS system. Supervised machine learning methods were used to create a model which predict the ASA physical status by analyzing the patient comorbidities and the medication. Model rankings were compared to 2 anesthesiologists. This model predicts ASA-PS similar to that of anesthesiologist. So we can say that AI can aid anesthesiologists in identifying the high-risk patients. Postoperative risk assessment. They improve the existing score and provide a new personalized risk. One of these is my surgery risk. This score is able to predict the 8 postoperative complications like acute kidney injury, sepsis, venous thromboembolism, intensive care unit admissions, mechanical ventilation, wound, neurological, and cardiovascular complication. The model has an AUROC of 0.85 for predicting the cardiovascular complications. This algorithm is superior performance when compared to 20 physicians. Other postoperative risk scores were postoperative pulmonary complications assessment can be done, acute kidney injury postoperatively, it can be assessed, and other postoperative complications like postoperative nausea and vomiting. Airway assessment. Trevor et al. Started from frontal facial imaging, developed a deep learning model capable of identifying difficult to intubate patients with performance superior to 2 conventional tests, Mallampatti and thyrometry. Kim et al. Proposed a predictive model of difficult laryngoscopy defined as grade 3 and grade 4 by Cormack-Lehane classification. Another developed a convolution neural network algorithm to evaluate difficult intubation just by evaluating the facial features by facial pictures. So for the next, coming on to the intraoperative anesthesia. For intraoperative anesthesia, several tasks can be carried out, such as identification during regional anesthesia with the help of ultrasound guidance, depth of anesthesia monitoring, automated drug administration, intraoperative pain management, intraoperative adverse event prediction, and postoperative complication risk. So, anatomical structure identification under ultrasound. A study investigated the application of artificial intelligence to detect anatomical landmarks during simulated epidural anesthesia. The USG transducer and needle were viewed in a 3D augmented environment. Epidural space was identified, and all attempts were successful in phantom as compared to 50% attempts using USG alone. Chan et al. Developed a machine learning algorithm in order to determine the needle insertion point using automated spinal landmark techniques. So you can see artificial intelligence, example of color overlay product produced by ScanNavan AI technique when scanning during the supraclavicular brachial plexus block. Here, the Accuro handheld device uses SpanNav3 AI-based spinal recognition technology to automatically detect bone landmarks and provide real-time 3D view of the scan plane. Examples of artificial intelligence color overlay for each peripheral nerve blocks can be studied. So here we can see all the nerve blocks are guided by artificial intelligence. Depth of anesthesia monitoring. In depth of anesthesia monitoring, AI has come into vogue. Machine learning approaches are well suited to analyze complex EEG data. A range of EEG-based signals are investigated to measure the depth of anesthesia. Neural networks and other AI methods have been applied to EEG power spectra to distinguish awake from anesthetized patient with depth of anesthesia indices like BIS. Additional parameters like heart rate variability have been investigated for their potential in approximating sedation levels. Automating drug delivery administration. Closed loop control of anesthesia involves continuous adjustment of drug infusion rates according to measured clinical effects. The CLADS, Automated Control Loop Anesthesia Delivery Device, has been designed to take inputs of all the patient parameters, run it through machine learning system, predict the outcome, and help in target management through predictive anesthesia monitor. This can be used for propofol infusion, opioid infusions, and muscle relaxants. It uses bispectral index to monitor the depth of anesthesia and guide anesthetic titrations. Hemodynamic feedback can also be used, non-invasive cardiac output monitoring, cerebral oximetry, EEG, nociception assessment, predictive monitoring, etc. With CLADS, anesthetic drug usage is more economical. Adapted system for use of volatile anesthetics called Improved Anesthesia Agent Delivery System have been designed to deliver inhalational anesthetics and propofol through closed loop control with bispectral index. Control systems that use machine learning have also been used to automate the delivery of neuromuscular blocking agents. They forecast the drug pharmacokinetics and control the drug delivery. 3 papers were identified that describe the use of artificial intelligence to control the mechanical ventilation and to automate weaning. So this is a closed loop anesthesia delivery system, or the CLADS, that is working on the principle of artificial intelligence. Intraoperative pain management can also be managed with the help of AI. Quantifying the nociception level of the patient, adjusting the analgesic drug infusion during anesthesia is still challenging. The authors use machine learning algorithms centered to this problem by evaluating the ANI, that is the Analgesia Nociception Index, as a guidance for variable for opioid infusion rate modulation. ANI values, together with hemodynamic information, outperform the non-specific traditional signs such as heart rate and blood pressure in order to quantify the nociception level. Intraoperative adverse event prediction has come into vogue. Several AI algorithms can assist anesthesiologists in intraoperative management by calculating the secondary indices. So, these algorithms can help anesthesiologists to improve intraoperative management by predicting the future events like the intraoperative hypotension or intraoperative desaturation. So, HPI, Hypotension Prediction Index, was developed, a machine learning model to predict the upcoming hypotension events map less than 65 by using features from arterial pulse waveform in 1300 patients. HPI was externally validated in 204 patients, and the AUROC achieved was 5 to 15 minutes before the hypotensive index was 0.95. It utilizes the machine learning and aims to predict hypotension before they occur, specifically when MAP is less than 65. It is a unitless number between 1 and 100, and higher values indicate a greater risk of future hypotension. The HPI algorithm analyzes the arterial pressure waveform and can predict hypotension 10 minutes in advance. HPI exceeding 85, the clinicians revive the electronic alerts and the treatment algorithms such as fluid administration, inotrope or vasopressors or observation, which they wanted to choose. Hence, early intervention can be done to reduce the intraoperative adverse event. Pre-science. For the prediction of intraoperative hypoxemia, pre-science is a tool can be able to assist anesthesiologists in predicting the intraoperative hypoxemia. Lundberg et al. Developed an AI model to predict intraoperative hypoxemia, which is defined as oxygen saturation less than 92% within 5 minutes. They extracted more than 20 preoperative and 45 intraoperative features at 1 minute intervals from the data. AI model has significant higher ROC than anesthesiologist. Other models that can be used for intraoperative prediction are phase, which can predict the hypoxemia, hypocapnia, hypertension, and phenylephrine and epinephrine infusions. AI in the postoperative anesthesia, it can be used for postoperative pain management, ACU monitoring, AI in the intensive care. So, for postoperative pain management, the machine learning was used to analyze difference in functional magnetic resonance imaging data collected from human volunteers who were exposed to painful and non-painful stimuli. They demonstrated that machine learning analysis of whole brain scans succeeded is accurately identified pain than analysis of individual brain regions traditionally associated with nociception. Machine learning can help in predicting opioid dose, individual opioid requirements, and the need for preoperative acute pain counseling. Many studies have successfully used remotely controlled pumps without physical intervention. PACU monitoring can also be done with the help of AI. Oster et al. Presented a predictive algorithm for detecting early signs of deterioration in PACU. This system had excellent results with early signs of identification with accuracy of 92.2%. Lee et al. Had developed a generalized additive model with neural networks capable of predicting mortality in patients undergoing general anesthesia. Integrated pulmonary index demonstrated high level of sensitivity in order to recognize significant and severe respiratory events. So, AI in intensive care can also be used. The introduction of machine learning in ICU is in its infancy. It can be used to predict the length of stay, ICU readmission, mortality rates, the risk of developing medical complications like sepsis, AKI, and ARDS. For operating room logistics, AI is not behind. AI plays an important role in optimizing the resources by precisely scheduling the operating room timings, tracking the movements and action of anesthesiologists, staffing and limiting of wastage of resources, coordinating with multiple spaces simultaneously in PACU or OR. They utilize the radio frequency identification tags to determine the location, orientation, and stance of anesthesiologist in the operating room. In telemedicine, AI has also come. The concept of teleanesthesia could allow distant preoperative assessment, could regulate anesthesia delivery from far off locations. Telemonitoring is also one step of telemedicine. Automated critical care systems can also be used. So, hospitals are taking advantages of new capabilities through 5G to reach out more extensive base patients by creating OT hubs within the premises or at different off-campus locations. With AI, one can be virtually present with the patient and colleague anesthesiologist to guide them in their perioperative period. Like teleanesthesia from Canada to Italy, even one can control all OT gadgets with smartphone AI apps. Teleanesthesia is not a new concept now, but combined with AI, it is very useful for teachings in CME and conferences like webinars. So India is not that far. India's indigenous surgical robot system, SSI Mantra, successfully conducted 2 robotic cardiac surgeries via telesurgery over a distance of 286 kilometers. It was done in 2025 itself. The surgeries were remotely performed at Manipal Hospital in Jaipur by Dr. Sudhir Srivastava, operating from Gurgaon using the advanced SSI Mantra 3 surgical robotic system. The first procedure, a telerobotic assisted internal mammary artery harvesting, was successfully completed in 58 minutes, and the surgery demonstrated a remarkably low ultra-low latency time of 35 to 40 milliseconds. AI in robots and anesthesia. Mechanical robots like Kepler intubating system, MechSleepy, and AI robots, RP anesthesia robots have come up. So, I control RP robot, the closed loop anesthesia system for intravenous drug delivery. It makes the decision and control the administration of IV agents such as propofol and remifentanil. The control of the RP takes into account neuromonitoring by using BESS. Robotic intubating system, it performs the intubation automatically or semi-automatically. It consists of single robotic arm controlled by a joystick. The robotic arm is linked to a video laryngoscope. So the robot can also do mask ventilation. Da Vinci robotic system demonstrated the first robotically assisted simulated nerve block placement under ultrasound guidance. The Magellan nerve block system used for peripheral nerve block, semi-automatic ultrasound-guided nerve recognition. It has an arm with nerve block needle at the end. The arm can be controlled with the help of a joystick. Pharmacological robots. AI-assisted closed-loop titration of drugs. It lessens the workload and free a solitary anesthesiologist to initiate, monitor multiple anesthetics simultaneously, and maintain a stable hemodynamics. So, Dr. Thomas M. Hammerling is known as a father of robotic anesthesia. His major contribution in the field of artificial intelligence were world's first totally automated administration of anesthetics in May 2008, which is MechSleepy. First robotic ultrasound-guided nerve blocks in humans using Magellan system. First robotic tracheal intubation by use of Kepler intubating system. AI in simulation. Teaching on simulation is necessary before handling actual robots. These are expensive and easily get damaged. Simulation environment to practice AI on mannequins before real-time patients. They are design and performance testing of new clinical equipments. So a simulator can also be worked with the help of AI. Cognitive AI. Cognitive AI is cognitive artificial intelligence is intelligent machine that thinks and behaves similar to humans. It mimics the human emotions, and the demand of cognitive AI is continuously increasing. The current AI research focus on realization of intelligence that makes the optimal decisions. So what is the future of artificial intelligence? It can minimize the system error and human error, which can be more user-friendly. It can be boon for ICU settings and pain clinics. They can be self-programmed with the help of microbiome in genomic medicine for personalized treatment. Within a few decades, technologies will flourish in the market. These efforts will continuously going to reduce the global burden of disease and cut down the healthcare expenses. Future of AI in operating room. Anesthesiologists will command all gadgets and lights of OT by artificial intelligence. OK Google, increase the heights of the OT table. Alexa, brighten and adjust the OT headlights. Siri, increase the cooling of AC. Monitors will be controlled and self-checked by AI. Our future anesthesia workstation will be operated by AI with just one voice command. So, what are the limitations? AI-based machines are fast, more accurate, consistent. However, they cannot be emotional or culturally sensitive. They are not able to replace the warmth, reassurance, and allaying of the anxious patient's fear. Anesthetizing patients requires much more skill and knowledge than merely titration of two drugs. The possibility of AI is limited. All humans' interventions are difficult to replace by robots, like placement of an IV cannula, etc. High initial capital investment is required. It needs to be user-friendly, and the person requires adequate training. Ensuring privacy and security of the data remains a major issue of concern. AI algorithms are prone to biases. Automation will reduce the human effort, but will also decrease the human workforce requirement and thereby reduce the job opportunities. It is important always to remember that AI algorithms will never be able to surpass human performance. Will AI replace anesthesiologist? No, AI cannot replace anesthesiologist. AI can control the gadgets, monitors, but anesthesiologists will be required to work at all times, filling the syringes, take clinical decisions in odd situations. AI will catch stupid mistakes and optimize patient care, but AI will introduce new errors that humans won't make. Handling of all tasks by automated robots is still the stuff of science fiction. An anesthesiologist will be required on site to achieve the task. So, in summary, AI has potential to impact the clinical practice of anesthesia. It will never be able to surpass the human performance. AI machines, however sophisticated it may be, but they cannot look the patient holistically. It cannot replace the clinician-patient relationship. And it must be only exploited as a tool for a specific purpose to improve patient care, but it should not be used to replace the clinician. Thank you.
Thank you, Dr. Deepika. You have indeed introduced all of us to the world beyond ChatGPT and for artificial intelligence. And
Thank
I
you.
think very rightly said that even though the books of science fiction by Philip K. Dick, which were written way back in 1950, they've come to life now, but they are still, AI should be used as a tool, and we should recognize the limitation, as well as we should be happy to have it in as one of our support staff in the OT.
Yes.
So very quickly now, we'll go through a few questions have popped up in our chat. The first question is for Dr. Rajni. Dr. Rajni, uh,
Yes.
it's been asked what would be the cost for formation of green OT when it would be cost efficient.
The normal cost of green OT would increase from 5 to 15 lakh depending on the required and the area of the OT that has been considered. And in if making it cost effective, we can contribute it to into the three parts or three types of benefit. One is short term, intermediate, and long term benefits. The short term benefits will be included with the amount of the volatile agents that would be used, which will decrease significantly and will provide us the short term benefit of the cost decreasing. The intermediate benefits would be from the reusable scrubs or the reusable OT gowns that can be used, which can be used for around 10,000. That will also help eventually. And the long term benefit that will be that can be compared are basically the things like the energy safety. The all the energy expenditure that has been used or that will be used eventually will be less, making the flow rates to be less, AGS switches to be off for some time, the ACs or the other lightings to be switched off, or the LEDs to be used in place of the other lamps that have been used traditionally. So eventually the total cost will be recovered in around 3 to 5 years, that whatever the cost was initially put in to make a green OT.
So, in summary, basically, there are a few efforts like using low flow anesthesia or reverting to regional anesthesia, which we can do
Yes.
immediately and they'll be cost effective within the short term. And if we want to invest in a greener OT, then we can recover those costs in about 5 to 7 years and maybe even less if we have more of workload.
Yes.
All right. So our next question here is for Dr. Ankita, and they've asked: is the individual not permitted to buy handheld ultrasound?
Okay. So I just want to give an example. Like, suppose if I'm a freelance anesthesiologist and if I go to different hospitals, if I plan that I will buy an ultrasound machine and I'll take that ultrasound handheld ultrasound portable machine with me to every hospital and perform the procedure, this is not allowed. So the ultrasound machine can only be bought by a facility that is registered. So in case we have a person who has a hospital, maybe a 200 bedded or a 300 bedded hospital, and if that hospital is registered with PCP and DT Act, then they can buy that portable handheld ultrasound machine, but that handheld ultrasound machine will not go out from that specific area where it is allowed to be or authorized to be used. So an individual cannot carry even if currently I'm working in a government hospital and if I decide that I personally want to buy a handheld ultrasound probe, so that is not allowed.
Excuse me, madam. That is allowed. That is what I want to inform. See, individual can buy. The thing is, as you predicted, the PCPNDT Act demands a license is to be there for the facility, for the purchaser, and for the person who is using it. 3 licenses are mandatory: place, person, and the area. So if I want to purchase ultrasound, I can buy it as an individual. But only thing is, I should not move it outside my facility. So it need not be in a hospital. I can purchase my ultrasound. I can keep it in one area. Again, if you want to do ultrasound in some other area, you can move it with the permission of the Joint Director. So you can inform the local Joint Director of Health Services. He is the permitting authority that this ultrasound is to be going to be shifted to that particular facility for this block. Every time you have to certify, I have not seen the sex of the baby, I will not disclose. And if you are going to use this ultrasound on a male member, absolutely the Joint Director will not have any questions. So immediately it will be permitted. So what I want to convey, the facility is not a must to purchase ultrasound. Anybody can purchase ultrasound, but if the person is not a radiologist, if the person is not an obstetrician, or if the person is not undergone a short-term course in ultrasound, they need a certificate. So now we are working, at least my agenda is only because lot of problems are with ultrasound. So even for ultrasound usage in post-graduation, you have mentioned. When I was a dean, somebody informed me like this. So what I have made, 1 month post-graduation in radiology department is compulsory for all anesthesiology postgraduates. That has been minuted and it is circulated. It is in the syllabus of the Tamil Nadu Dr. Medical University. So now I am sending across to all the universities to make it mandatory in that place. So the point is individual can buy, no problem. But usage, you have to be very careful. Again, we have to work that anesthetic should be exempted from PCPNDT Act. So that is a separate thing. I am working on it. We will do it.
Okay, sir.
And also, I'd like to add, sir, that each use has to be documented and it can be audited by the government. So it has to be registered and it has to be documented as to how it has been used. If like sir has said, if it is moved to another facility by some decision, then it has to be documented and it can be audited.
See, if you are purchasing it, automatically all the rules will be given to you. So documentation is a must. Now for obstetrics, they have made it mandatory. At the time of scanning itself, a report is to be given to the patient and it should be uploaded in the website. So that they claim there will not be any change in future this thing. So now more of a clerical work as far as ultrasound is concerned. More of a clerical work, but we have to oblige because the rules of land is to be obliged.
Yes, the regulatory pathway has to be followed.
Yes. Probably we can have one artificial intelligence for that, which will do all clinical clerical work.
Clerical work.
We will do clinical work.
For Dr. Deepika, we have a question, which I think you have also answered in your last slide, but just to reinforce it, whether anesthesiologists will be replaced by AI, and if not, what will be the role of the anesthesiologist once AI is integrated into our practice?
So I would like to re-emphasize that anesthesiologist cannot be replaced by AI. AI can only assist the anesthesiologist, or it can help the anesthesiologist to make decisions in some difficult scenarios. AI should help to refine our work in the field of anesthesiologist, not supplement our work. Even the research work is coming into practice, but we should all focus that the practice of residents should be evidence-based rather than based on AI. Some of the people are like fully dependent. They are not learning the things and they are working on the basis of AI only. So we should emphasize that AI should only be used to supplement our work, but the work should be evidence-based rather than AI assisted. Thank you.
Madam, you
Yes,
have
sir.
mentioned when AI can intubate, when AI can assess the spinal root or the canal or epidural space, but you are saying the human will be utilized only to load drugs, like IV drugs. You have mentioned it that will the robot will not do that. Loading the thing. You say for loading, it will be done by
Loading and to
human.
make critical decisions as well,
That
sir.
is right, but your slide mentioned it is loading. The anesthetist cannot be replaced because human beings are necessary to load. That is the thing is loading will be done by human and injection will be given by robot. This is fine artificial intelligence.
But the critical decisions and the decision making and the patient
But
care.
madam, how do you feel? You are saying if the question is anesthesiologist cannot be replaced. Okay, anesthesiologist can be replaced by any other doctor, because if there is a physician, he can manage it, because artificial intelligence is going to give the clue. Everything artificial intelligence will intubate, and it will say mainly thing if there is hypotension, the physician himself knows. So, in what way you think anesthesiologist can excel after the advent of artificial intelligence?
Mostly the difficult decision making. Artificial intelligence, they cannot take, I think. That has to be
But the
done by
training, the
anesthesiologist in
anesthesiology
critical
training,
situations.
anesthesiology training cannot be imparted to the
Yes,
non-anesthesiologist,
yes,
because it is a different terrain almost, OT and ICU.
The
yes.
perioperative setting is unique to the anesthesiologists. For the
Yes.
physicians, they have never entered this environment, and they do not understand the technicalities and the cognitive overload that can occur here. So, uh,
If there are no questions, we can wind up the session. No questions?
I think these are the only questions that were there from the audience.
Okay. If you want to pass any concluding remarks, you can do, madam.
Okay, I think all our speakers did a wonderful job, and they have touched upon unique but very relevant topics in today's anesthesia world. So, just to recap, I think we should make our OTs greener, more focus friendly, and start looking ahead to integrating AI in our daily routine. So, with that, I'd like to thank Sir for giving us all an opportunity to share these topics with our listeners. And, Sir, over to you.
Thank you. It is a totally new dimension that you have given from the routine webinar topics. So, literally, I enjoyed. So, as a Thanksgiving gesture, I thank Dr. Rajni Khalia, the senior resident. She has given a wonderful lecture about this green OT, because that is evolving now. And it was followed by Dr. Ankita. It was a fabulous lecture. The focus is she has focused on focus. Complete. It is complete. She has not deviated, and we are very happy to see that, because if anybody listen, it will be coming as a YouTube recording. So if any postgraduate watches this, it will be very nice for him to answer the questions in theory as well as practical. Simply, it is a fantastic lecture. She has given all the outputs of focus. Really good. And it was followed by naturally intelligent Dr. Deepika talking about artificial intelligence. But I don't know, madam is upset. So with that facial grimacing, madam has discussed everything about artificial intelligence. So it is quite nice, and she has started from the basics of artificial intelligence. It reminded me some 15 years back, I delivered that national conference in Bangalore about this artificial intelligence. At that time, I was searching for literature, so many things. At the time only, I was talking about the superficial learning, machine learning, deep learning, and even after 15 years, I think it need not be repeated, because already people are there, and even we had a session TCI, TIVA with the AI. So it is advanced like this artificial intelligence. Now even all cars are equipped with artificial intelligence, making us very lazy. The computers have made the brain work very delicate. It is depressed. Brains are not working already. Even people are having autocorrect in spelling. So I don't know, in future, if I write Ankita, the computer itself will correct it. No, no, she is Ankita Bhasin. You have missed that Bhasin. Everything will be corrected. So I could not even imagine, because we are seeing the developments within 5 years. There is, with the advent of smartphone, everything is monitored in a smartphone, including your focus, everything. So you have thrown a good light, and it was excellently moderated by Dr. Aditi. Very cool, very cool. So she had a green OT, focus, and this artificial intelligence in her mind. And with all smiling face, she has arranged. So special thanks. She has arranged this webinar. She has fixed the faculty. Even she has given all the messages which I require. She has sent the messages. So I thank the entire Chandigarh team. And today you have opened my eyes also regarding the developments, mainly the pitfalls with ultrasound machines. So fortunately, I will be joining the governing council of ISA National in November. I will take all your help, because my only agenda will be to make this ultrasound, which is very easier for the anesthesiologist, considering the legal clutches. So at that time, I have talked to few people from Karnataka. I will definitely take your help, mainly this focused lady, Dr. Ankita, and this Aditi. You please help me in that. And we will, within a year, we will try to change. Another one, anesthesiology is to be changed as anesthesiology and perioperative medicine. You have mentioned. So I am interested in doing only this. And anesthesiologists should be exempted from PCP Act. We will see how it works out. We will pull all the strings in medical, non-medical, political, administrative, all arenas. You please help me, as you are in nearing the headquarters, near the headquarters, Delhi. You please help catch hold of any person in this health department, so that I will catch hold of him from November officially. Till that time, I will do it unofficially. We will work together. Thank you. I request the clarinet to pass the concluding remarks and wind up the session.
So, thanks to all the dignitaries present here, Clarity is really glad to have all these brilliant people together in this session today. And I really hope that you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone.
Thank you.
Thank you so much. Have a
Thank
good
you,
day.
everyone. Thank you.
Thank you, sir. Thank you so
Thank you,
much.
sir. Thank you.